Hello, dear students. It's me, Sarah Galal, Assistant Professor of ENT Department of Azerbaijan Medical University. Today, we're gonna discuss with you our first lecture. Today, we have very interesting content. We will discuss about the upper airway anatomy and function, anatomy, physiology, and pathophysiology of the pharyngeal lymphoadenoid tissue, valvular ring, adenotonsillar diseases, classification of tonsillitis, acute and chronic tonsillitis, diphtheria, and differential diagnosis and complication of acute tonsillitis. The upper airway anatomy, we know the nasal cavity, oral cavities, and pharynx and larynx include the upper airway. The pharynx must serve two conflicting functions. It must rapidly constrict during the swallowing, and breathing and speech must be interactive during the swallow. Extending basal skull to the C6 in adult and C5 in infant. You see, it is the pharynx, it's the whole pharynx. It's divided into three parts. The nasopharynx, which part is convenient to the nasal cavity, we call it nasopharynx. Oropharynx, it's convenient to the oral cavity, and hypopharynx, we mean this area. Another name of this is the laryngopharynx, because this part is convenient to larynx. In that this slide we can see more structures with detail. Even we can see the boundaries. For example, the anteriorly nasopharynx is connected to the nasal cavity. The laterally here is the auditory tube, which we call the eustachian tube. Even you can see this part is the roof. There's a sphenoid with this occiput area. Laterally, we said it's the pharyngeal openings of the eustachian tube. Posteriorly, prevertebral muscles and fascia. And the floor is the soft palate. Anteriorly is definitely posteriorly, and oropharynx where the nasopharyngeal isthmus. Okay, in this picture we can see even not only the opening of auditory tube, even we can see the posterior rosemellar and the esophageal fold. The examination of the in that picture you can see it is the backside view. It's the same from the behind. Superiorly, this part, it's the nasopharynx, it is the oropharynx and laryngopharynx. Examination of the nasopharynx, there are two methods. Directly we are using the scopes and flexible and rigid scopes, but before that we use it to the posterior rhinoscopy method. So what is the posterior rhinoscopy? For the posterior rhinoscopy, we can insert a small mirror inside the mouth, and through this mirror we can see the choana. Even in that picture we can see the adenoid vegetation here. Now about the functions of the nasopharynx. There are main function is the airway, because it's the air conduct for air to its way to the larynx and trachea, middle ear ventilation. The eustachian tube ventilates the middle ear and equalizes air pressure on both sides of tympanic membrane. Dysfunctions of the eustachian tube can affect the middle ear. The resonance is a part of resonating chamber for the voice production. The drainage, we mean it's a drainage channel for nasal and nasopharyngeal mucus secretions. And nasopharyngeal isthmus, it cuts off the nasopharynx from oropharynx during swallowing, vomiting, gagging, and speech. Speech, for example, when we say the patient just say the Coca-Cola or cuckoo, something like that, then the soft palate divided oropharynx from the nasopharynx. Oropharynx. Now about the oropharynx. For examination of oropharynx, it's very easy. We need just a tongue depressor. Then we can see this scene. You see the superior is the soft hard palate, palatal bone. The posterior is the soft palate, and at the end it is the uvula. Even we can see the anterior arch and posterior arch, and between them we can see the tonsils. These tonsils we call palatine tonsils. The laryngopharynx, it's the superior edge of the epiglottis and the root of the tongue. Form the border between the oropharynx and laryngopharynx. The lower end of the laryngopharynx narrow into a funnel, and it continues with the esophagus. Along the sides of the entrance to the larynx, between the entrance and the lateral walls of the pharynx, are found the preformed recesses. Food moves to the esophagus by these preformed recesses. The pharyngeal wall consists of 4 layers. The main layer is a fibrous membrane, which is lined with mucus on the inside and with muscles on the outside. All parts of the pharynx are involved in the respiratory function, but if the nasal passages are abstracted, breathing is accomplished through the mouth. The protective function of pharynx consists in when reflex contraction of the pharyngeal muscles when a foreign body or an irritating substance. Inspired air is first warmed in the nose and then in the pharynx, where it is also cleaned from the dust who sticks to the mucous lining of the pharyngeal walls. The physiology of the palatine tonsil is not autonomous. It is the part of the function of the entire lymphatic system of the body. During the first years of life, the lymphoid structures of the pharynx attain maximum growth, but during the sexual maturation, they undergo partial and gradual back development. In that slides, we can see the Valdeir ring. We call this ring why? Because it is an interrupted circle of protective lymphoid tissue at the upper ends of the respiratory and alimentary tracts. You know, we have 2 paired and 2 unpaired. Together 6 tonsils. Okay, 2 paired and 2 unpaired. The paired one, it is unpaired one, the superiorly, it is the pharyngeal tonsils. Another name of the pharyngeal tonsils, we mean the adenoid. It is located in upper midline in the nasopharynx. And lingual tonsils, it's the downly, it is located in under the mucus of the posterior third of tongue. The tubal tonsils, it's the smaller tonsils, it's the around openings of the auditory tube, and which the visible, and sometimes when we mean just the tonsils, we mean the palatine tonsils, which either sides of our pharynx we can with that. Even in previous pictures we saw it. Okay, you know, all this located as around the ring, and that's why we call this the Valdeir ring. Okay, it's again, you can see the pharyngeal tonsils. It is the superior inferior lingual tonsils, just the lateral bands of the lymphoid tissue. We mean just auditory tube tonsils, tubal tonsils, and palatine tonsils. Together they form the Valdeir ring, and it's covered by the respiratory epithelium, so the pseudostratified stellated columnar epithelium. About the anatomy of the tonsils, palatine tonsils, the ovoid-shaped are located laterally into the oropharynx and bordered by the following tissues: the deeply superior constrictor muscles, anterior palatal muscle, posterior palatopharyngeus, superior soft palate, and inferiorly lingual tonsils. The blood supply of the palatine tonsils is very important part, because after the tonsillectomy, during the tonsillectomy, even during and after the surgery, we should be aware of the bleeding, and we see that it is a very rich vascularization of palatine tonsils through the external carotid artery branches. You see, it is the superior pole vascularized by ascending pharyngeal artery and lesser palatine artery. Inferior pole, it is the facial arteries, branch dorsal lingual artery, and ascending palatine artery. About the venous outflow, the plexus around the tonsillar capsule, the lingual vein, and the pharyngeal plexus. The lymphatic drainage is surrounded the superior deep cervical nodes and jugular the gastric nodes. The sensory supply of the palatine tonsils is innervated by the glossopharyngeal nerve and the lesser palatine nerve. Now about the functions of tonsils. It has just four important functions. The first is immunity, lymphocyte formation, antibodies formation, and it's the barrier to infections. We said that it produces lymphocytes or activates the synthesis of immunoglobulins. A ring of the lymphoid tissue in the oropharynx and the nasopharynx are the first lymphoid aggregates in our digestive tract thought to play a role in immunity. In that table, we can see the differentiation of normal adenoid and tonsils, palatal tonsils. It's the adenoid women pharyngeal and tonsils women palatal tonsils. About the examination of the pharynx, inspection. The first we said the importance the inspection and palpation. The regional lymph nodes of the pharynx are palpated. The submandibular nodes, the nodes in the retromandibular posterior cervical nodes should palpate. There is a mesopharyngoscopy using a spatula in the anterior two thirds of the tongue should be pressed, and the normal soft palate is readily movable. The mucosa of the soft palate of the vulva and the anterior and posterior palatal arch should then be inspected. Okay, here we can see it is the soft palate, vulva, and the palatal tonsils. We can see, but we can see all this after when we just pressing the tongue. About the grades of the palatal tonsils, there are four grades. Just this one, it's between them, between the arch. We call this even the smaller. We call this the first grade, and you see it is the fourth grade. During the grade 4, they just touching each other's, and we call this touching each other's. We call the kissing tonsils. When tonsils meet in the midline or overlapped, it's the kiss tonsils. It is blocked the airway, making breathing and swallowing difficult. It can cause the sleep apnea, loud snoring, mouth breathing while sleeping, and feeding problems. About the pharyngoscopy, we told about that a warm nasopharyngeal speculum and a spatula are used for this purpose. Okay, this method we call the epipharyngoscopy. And if we could not just examine with mirror, we should just do just a palpation of the nasopharynx. The doctor's right index finger should pass behind the soft palate into the nasopharynx to feel the clana, the wall of the nasopharynx, and the lateral walls. But I should say that now we are not doing this methods because now we are using just the flexible scopes and rigid endoscope nasal, and we are doing nasal endoscopy, and it's enough for analyzing of the middle, the nasopharyngeal area. Even nasopharyngeal area, even the hyperpharyngeal area. Okay, here it is the hyperpharyngoscopy. It is the same as the epipharyngoscopy, but now we just change the direction of mirror. Okay, it's very for understanding all the diseases, the palatal diseases, we should understand the structures of it, the functional and structure of the palatal tonsils, about the lymphoepithelial barrier of tonsils. It has just a fourth barrier. The first barrier is the mucosa. The disturbing of the first barrier leads to the angina. I mean, just angina. It is the acute tonsillitis. If the second barrier, histohematic barrier, is damaged, vascular walls of tonsils, we mean histohematic. We mean just the vascular walls of the tonsils. If it is damaged, the microorganisms pass through the vessels, and it leads to a metatonsillar disease. We're gonna talk at the end of the lecture. The third barrier, we mean just the capsule of tonsils. If it is passed through the capsule, it leads to a paratonsillar disease. And if it's just goes through the fourth barrier, the hypertrophy of the lymph nodes is creating. In that picture, we can see just a microscopic view of the inflamed tonsils. But about the pathogenesis of adenotonsillar disorders. The pathogenesis of infectious inflammatory disease in the tonsils and adenoids has its basis in their anatomic location and inherent function as organs of immunity processing infectious material and other antigens, and then it's becoming paradoxically a focus of infection and inflammation. Inflammation and loss of integrity of the crypt epithelium result in chronic cryptitis and crypt obstruction, leading to stasis of crypt debris and persistence of antigen. Bacteria, even infrequently found in normal tonsil crypt, may multiply and eventually establish chronic infection. What is the tonsillitis? Okay. Tonsillitis, it is the inflammation of pharyngeal tonsils. This inflammation usually extends to the adenoid and lingual tonsils, therefore the term pharyngitis may also be used. The lingual tonsillitis refers to isolated inflammation of the lymphoid tissue at the tongue base. About the classification of the tonsillitis, the tonsillitis may be as acute, recurrent, chronic, and the tonsillitis as this. Acute, we mean it's the episodic, it's related just a decreasing of immunity which leads to auto-infection. Maybe epidemically, it is the already guessed infection is damaged. Exacerbation of chronic tonsillitis, and maybe such as the exacerbation of chronic tonsillitis. What causes the tonsillitis? The most common microorganisms causing the tonsillitis, they are viral and bacterial. The viral, the adenovirus, rhinovirus, cytomegalovirus, herpes simplex, Epstein-Barr aggressive virus, and the papillocoronavirus also is the reason causing factors, causing viral factors. The bacteria, most of them to the group A beta hemolytic streptococcus, we just call them GABHS. We call them just such as the viral, bacterial or bacterial infections and immunologic factors lead to tonsillitis and its complication. Overcrowded conditions and malnourishment promote tonsillitis. Most episodes of acute pharyngitis and acute tonsillitis are caused by viruses such as the we count of them. Bacteria cause the 15–13% of cases of pharyngeal tonsillitis. Anaerobic bacteria play an important role in a tonsillar disease. The most cases, we said, it is the group A bacterial, beta hemolytic streptococcus is the big reason of the bacterial reason. Immunoglobulin coating of pathogens may be important. The initial induction of bacterial tonsillitis. Okay, about the classification of tonsillitis. Actually, it's divided. This classification, which we demand on you during your exam. It's post-Soviet country and just our country, just our exam event. We will demand on you this classification. It is the divided acute and chronically, and the acute tonsillitis also include the banal, atopic infection, systemic vascular diseases. The banal, we mean it is also divided as a catarrhal, follicular, lacunar, and the mix. But the ICD code of the acute tonsillitis, it is the G03. But you see, we mean G03, we mean actually the streptococcal tonsillitis, and there are so many different code of the other type of the tonsillitis, acute tonsillitis. Acute tonsillitis is the international classification, and they also divided it as acute superficial, parenchymatoses, the follicular, and the membranous tonsillitis. Acute tonsillitis, catarrhal superficial. Here, it is the part of the generalized pharyngitis mostly seen in the viral infections. During the follicular infection, infection spread into a crypt with purulent material, presenting its opening of crypts as yellow spots. Acute parenchymatous tonsil uniformly enlarged and congested. Acute membranous, it's the low stage of acute follicular tonsillitis where exudates coalesce to form membrane on the surface. We will have the separately example about that. In that slides you can see it is the bacterial view, but this is the non-bacterial, this is the viral view. In the viral view you can see there is the red swollen tonsils and the throat there is the redness. But during the bacterial, there's the swelling wool, you can see, and you can see the whitish spots over the palatine tonsils. During the bacterial tonsils, we can use just antibiotics. We can indicate the antibiotics. Acute catarrhal tonsillitis, the pathological changes are characterized by pronounced dilatation of the small blood and lymphatic vessels in the parenchyma of the tonsils, thrombosis of small veins. That's why there is the redness. The once it is acute and is marked by dryness, burning, and thickening in the throat, then swallowing becomes slightly painful. The patient complains of general indisposition, fatigue, and headache. The body temperature is usually subfebrile and insignificant inflammatory changes in the peripheral blood are found. During the pharyngoscopy reveals diffuse hyperemia of the tonsils and the margins of the palatine arch, and the tonsils are somewhat enlarged. The regional lymph nodes are often slightly enlarged, and this disease usually lasts just 3-5 days. Okay, this picture, it is the typical view of the acute catarrhal superficial tonsillitis. About the follicular tonsillitis, the disease usually begins with elevation of temperature to 38-39. The patient feels strong pain during the swallowing. The pain radiates into the ear. Elevation is often increased. The changes in the blood are often pronounced. Neutrophilic leukocytes count, it's increasing. As a rule, the regional lymph nodes are enlarged. Their palpation is very painful. And during the pharyngoscopy, we reveals diffuse hyperemia, infiltration of the soft palate and the arch, and the tonsils are hyperemic and enlarged with numerous yellowish or yellowish-white spots. You see, elevated over the surface. These formations are suppurating follicles. This disease lasts 5-7 days. Now we're gonna show you just a typical example of the follicular tonsillitis. You see, it is during the follicular we said it is the special affecting the crypts. Okay, it's also the example for the follicular tonsils. During the follicular tonsillitis, we can see the point-like spot. Lacunar tonsillitis. Lacunar, it is the same as the membranous labyrinth. Lacunar tonsillitis usually runs a more severe course than a follicular. Pharyngoscopic picture is characterized by enlargement of hyperemic tonsils, which are covered with isolate of the yellowish coat, first in lacunar orifices and then over the entire surface of the tonsils. Toxemia is severe and it is therefore necessary to monitor the cardiovascular and the respiratory functions. Treatment. Our rational treatment includes the sparing conditions, local and general therapy. The patient must remain in bed during the first days of the disease and then abstain from physical work. The patient should be separated from the others. He should use separate dishes. Okay, in that picture we can see it is the example of membranous tonsillitis. You know, we should know that this membranous tonsillitis is such a view. Sometimes we need this to differentiate another types of the acute tonsillitis. I mean the specific disorders. Okay, it is the membranous. We mean the lacunar angina. It is the same. The follicles when coalesced, it's the form a wide patch over the tonsils. Lacunar and membranous we mean the same. Treatment includes also gargling, the warm solution, and warming compress should be applied to the neck. Sometimes they said that and antibacterial therapy is very important for preventing the complications. Okay, we said that this view, the white spots, the white patch, sometimes we can see the white patch during the diphtheria, the Vincen, all these during this tonsillitis, acute tonsillitis stuff, we can see the same view. Okay, now a little bit other types, other atopic tonsillitis. Atopic tonsillitis, we mean it includes the Plaut-Vincent's angina. Plaut-Vincent's, it is the same as the Szymanowski-Vincent angina. You know, for Soviet countries book, it's written as a Szymanowski-Vincent and Plaut. But if you will just Google it, you cannot find in the foreign literature as the same name. The herpetic angina and the fungal angina. Most interesting of them, it is the Plaut-Vincent's angina. We mean the Szymanowski-Vincent. Another name is the ulcerous necrotic tonsillitis. You see, the symbiosis of Bacillus fusiformis and the Spirochetes buccalis that is often found in the mouth of healthy people in the virulent state is believed to be the pathogenic factor. The morphological changes are characterized by necrosis of the surface of the tonsils with formation of an ulcer whose floor is covered with a loose fibrinous membranous underlaid by necrotized lymphoid tissue. The patient complains of discomfort in the throat during the swallowing, fetid breath, and hypersalivation. The body temperature is usually normal. Interesting part is the leukocyte count moderately increases. Now we're gonna show you the pictures of Vincent's angina. You see there is the bleeding. Why bleeding? Because there is the ulcer. Because this is ulcerous necrotic disease. The symptoms of the Vincent's angina, the patient's complains of unilateral sore throat that increases intensity over several days with an associated report earache on the same side. In addition, the patient's complains of a bad taste in the mouth and a fetid breath. The diagnosis is based on examination. There is a deep, well-circumscribed unilateral ulcer of one tonsil. The base of the ulcer is gray and bleeds easily when scarred with a spike. There may also be an associated submandibular lymphadenopathy. Vincent's angina is diagnosed using a gentium violet stained smear of the pharyngeal exudate, which demonstrates the presence of the bacterium and spirochetes. We said this. The treatment consists in tending to the mouth cavity, cleaning the ulcers for necrotized matter, gargling with disinfectant solutions, and the surface of the ulcer is treated with an iodine tincture, nitrate, and other solution, and antibiotic therapy. We should use sometimes the penicillin and clindamycin, and sometimes the surgical debridement are the recommended therapy, recommended treatment. During the infection diseases, maybe acute tonsillitis as the diphtheria, maybe scarlatina as how we say the scarlet fever, measles during the syphilis, AIDS. During all these diseases can show themselves as acute tonsillitis. The diphtheria is an acute infectious disease caused by the Corynebacterium diphtheria, the left-ear bacillus, transmitted mainly in an airdrop way and characterized by the symptoms of general intoxication, local inflammation of the mucous membranes, mainly with the formation of fibrinogenous fur, and typical complications on the part of the nervous system, cardiovascular system, and exsurgery system. The clefts discovered in the diphtheria, pathogen Corynebacterium diphtheria, in the sections of diphtheria membranes in 1883. In 1884, Loeffler extracted it in clean culture. About the classification of diphtheria, in accordance with International Classification of World Health Organization, diphtheria is divided by the following clinical forms. Just after localization of local process as a diphtheria of tonsils, diphtheria of nasopharynx, diphtheria of front department of nose, diphtheria of larynx and trachea, diphtheria of other localization, skin, wound, and other. After by expressed of general toxic by the character select the following variants the terms of appearance and weight of complications motion of diphtheria may be subclinical, easy, middle, severe, heavy, hypertoxic, bacterium and bacterium carrier. After by widespread in process may be localized, widespread and combined. After by character of local change may be capsule, islands, and membranous fibrinose. In the pictures, in the slides, we can see the clinical appearance in diphtheria infection includes the gross inflammation of the pharynx and tonsils marked by grayish patches, which we call this grayish patch as a pseudo membrane and swelling over the entire area. Okay. We said it may be the local, diffuse, and toxically. As a clinical symptoms manifestation, it happens sometimes after just 2 to 5 days. The incubation period lasts 2 to 5 days, but sometimes it's range of 1 to 10 days. At first, the patients present with malaise, sore throat, and moderate fever. The tonsils are swollen, either both or mostly, and erythema is strictly localized. By the end of the first day, or by the beginning of the second day, the cover gets the characteristic diphtheria cover properties. It's dirty gray or yellowish, rather thick, rises above the mucous membrane surface. It cannot be removed without bleeding. It is the significant sign of the diphtheria because sometimes when it is covered the membranous labyrinth, when we during the membranous labyrinth, lacunar angina, it is the same view. But how we can differentiate them each others during the diphtheria? When we just try to remove it, there is the hemorrhages happening. And plenty of fibrin and diphtheria battle can be discovered under microscope in endomicroscope. The manifestation of general intoxication remain insignificant. A headache, malaise, poor appetite. In the case when the disease is not treated with serum, the cover appears on the bulla, soft palate, nasopharynx. Nasal cavity on the process goes downward to the larynx. Laryngeal involvement leads to obstruction of the larynx and lower airways. The difference, the clinical significant difference is that during the diphtheria, this white patch is exposed to the tonsils. During the acute membranous labyrinthitis, the white patch does not expose the tonsils, but during the diphtheria, it's spreading to other area, mainly the uvula. If we can see the white patch of the uvula, we should suspect immediately of the diphtheria. The typical forms sometimes develop on the third, fifth day of the disease from the localized form when the process affects the nasopharynx and oral cavity. More often it develops as it's from a very beginning. At the mouth examination, you can see the tongue is dried, the fauces are dark red and hydropic, and there is usually dirty gray fur in one tonsil. It cannot be removed by catarrhal. This cover affects the entire tonsil and passes to the uvula, which we showed the first in the previous pictures. On the second or third day, the disease is in a full swing, and it is not difficult to clinically diagnose toxic diphtheria. It is the view of the toxic diphtheria's view. Nasopharyngeal diphtheria with the blood discharge and the bull neck. It is the bull neck appearance of diphtheria. It is the cervical lymphadenopathy is creating. A child with the bull neck. It's another example in the children. About the skeletal angina or scarlet fever, it is the disease which can occur as a result of group Streptococcus infection, also known as a Streptococcus pyogenes. There is a scarlet fever. It looks like as a skeletonous erythema, and it is the result of the vasomotor reaction give us such the view, and it is appears early hours in disease, and it is disappear after 2 days. All this is differs with other types with the duration also. It's the main part of this. It is in that picture we can see it is the symptoms include the sore throat, fever, headache, swollen lymph nodes, and it's the characteristic rash of the during the scarlet fever. The rash is red and feels like the sandpaper, and the tongue may be red and bumpy. It most commonly affect children between the 5 and 15 years of age. Another name of the skeletal fever, we call this strep throat because the etiological factors. The typical symptoms of streptococcal pharyngitis, it is the same with the sore throat, painful swelling, fever typically over the 39 degree, the fatigue enlarged and reddened tonsils with yellow or white exudate presence, enlarged and tender lymph nodes usually located in front of the neck. The following symptoms will usually be absent: cough, hoarseness, runny nose, diarrhea, and conjunctivitis. Their presence indicates it's more likely a viral infection. During the pharyngoscopy, we can see this erythema, we can see this view, the throat, a child with a positive throat culture for streptococcal pharyngitis, the streptococcal pharyngitis, which is the usual presentation of scarlet fever in combination with the characteristic rash, commonly involves the tonsils.